Shortened antimicrobial treatment for acute otitis media in young children. Definition: acute otitis media is an acute inflammation of the middle ear and may be caused by bacteria or virus. A subtype of acute otitis media is acute suppurative otitis media characterized by the presence of pus in the middle ear. In around 5%, the eardrum perforates.
Pathology of otitis media. When the eustachian tube is blocked due to allergy or infection in the upper part of the respiratory tract, fluid accumulates in the middle ear behind the eardrum. This causes an infection and the middle ear gets inflamed, a condition known as otitis media. The buildup of pressurized pus in the middle ear causes earache, swelling, and redness. Since the eardrum cannot vibrate properly, one has decreased hearing. Also, there is a feeling of fullness or pressure in the ear with dizziness, loss of balance, nausea, vomiting, and fever. Sometimes the eardrum ruptures and pus drains out of the ear. But more commonly, the pus and mucus remain in the middle ear due to the swollen and inflamed eustachian tube. This condition is serious because of the severe earache and hearing loss it can create. Hearing loss, especially in children, may impair learning capacity and even delay speech development. Otitis media is also serious because the infection can spread to nearby structures in the head. Thus, it is very important to recognize the symptoms of middle ear infections and to get immediate attention from your doctor. However, if it is treated promptly and effectively, hearing can almost always be restored to normal. Tips to prevent middle ear infections for infants. Appropriate management of colds, flu, and sore throats, and of hay fever and other allergies helps prevent middle ear infections. While breast or bottle feeding babies, avoid holding them in a horizontal position. A semi-inclined position prevents the milk from entering the eustachian tube and infecting the middle ear. Avoid contact of the baby with objects handled by people who have cold.
Application in medicine. Pharmacotherapy, amoxicillin clavulonates, trimethoprim, sulfamethoxazole, cefixime, etc. Surgery, tympanocentesis, meningotomy with insertion of ventilating tube. Limiting the duration of antimicrobial treatment constitutes a potential strategy to reduce the risk of antimicrobial resistance among children with acute otitis media. Pros: clinical success occurs in more than 16% of patients, even when bacteriologic eradication is not achieved. Eventually, almost all patients improve. Cons: many children with acute otitis media do not benefit from antimicrobial therapy, either because the illness is not of bacterial origin or because their immune systems clears the infection without use of a drug.
Acute otitis media is the most common indication for which children in the United States receive antibiotics. Current guidelines recommend a 10-day course of antibiotics for children under 2 years of age. But given the growing concern about antimicrobial resistance, can the duration of antimicrobial treatment be shortened without changing clinical outcomes? In this study, investigators randomized 520 children 6 to 23 months old who had acute otitis media during the respiratory infection season to treatment with 10 days of amoxicillin clavulanate or to 5 days of amoxicillin clavulanate followed by 5 days of placebo for each episode, and assessed whether the reduced duration was non-inferior to the standard duration. Symptoms were tracked through the acute otitis media severity of symptoms score, which includes ear tugging, crying, irritability, difficulty sleeping, diminished activity, diminished appetite, and fever. The primary outcome was clinical failure, defined as worsening symptoms or otoscopic signs of infection, or failure to achieve resolution of symptoms and signs. Patient enrollment was stopped early when the non-inferiority endpoint was achieved. Clinical failure was seen in 34% of the children who received 5 days of antibiotics, significantly more than the 16% of children who were treated for 10 days. When both groups were combined, failure rates were found to be higher in children who were exposed to 3 or more other children for 10 or more hours per week, and higher in children with bilateral rather than unilateral infection. There was no difference between the groups in rates of recurrence, adverse events such as diarrhea or diaper dermatitis, or nasopharyngeal colonization with penicillin-resistant pathogens. The authors conclude that for acute otitis media in children 6 to 23 months old, reduced duration treatment resulted in higher rates of clinical failure without reducing adverse events or antimicrobial resistance. Full trial results are available at nham.org.
Issues in Ecuador. More than 2/3 of children will experience one or more attacks of acute otitis media by the age of 3, and about half experience more than 3 episodes. More than 65% of episodes occur in children under 10 years of age.
An acute middle ear infection is one of the most common illnesses affecting babies and young children. About 1 out of 10 children gets a middle ear infection in their first 3 months of life. A middle ear infection usually develops after a cold, sore throat, or sinus infection. The following symptoms may be signs that a young child has an acute middle ear infection: earache, made noticeable by the child rubbing and pulling the ears, or frequently shaking his or her head; fever several days after a cold or sore throat has started; no response to speaking or sounds of normal volume level that the child would typically react to; irritability, frustration, restless sleep; more frequent and more intense crying than usual; loss of appetite or vomiting. Many of these symptoms are linked to the pain that a middle ear infection can cause. This pain mostly comes from the eardrum. This high pressure in the middle ear can cause the eardrum to become so tightly stretched that the child will experience pain, and his or her hearing will be affected. Sometimes, if the pressure in the middle ear is very high, the eardrum can also burst. The resulting rip in the eardrum usually closes on its own again, but fluid may continue to leak from the ear for several more weeks. Usually, an acute middle ear infection will heal on its own. In about 9 out of 10 children, symptoms get better after 2 or 3 days at the latest. Yet for some children, it may make sense to use antibiotics, however. According to scientific research, this is the case when a child under the age of 2 years has an infection in both ears, or a child has pus leaking from the ear. These symptoms indicate that the infection has been caused by bacteria, which antibiotics are effective against. And if symptoms do not improve after a few days, or if they get worse, or if new symptoms start, antibiotics are also a good idea.
Conclusion. Among children 6 to 23 months of age with acute otitis media, reduced duration antimicrobial treatment results in less favorable outcomes than standard duration treatment. In addition, neither the rate of adverse events nor the rate of emergency of antimicrobial resistance was lower with the shorter regimen.